start this auditor session, if you would, just a quick disclosure for any state entities, EMS, or others that are in the room. So the expressed opinions of the panelists today don't necessarily reflect NCQA or Inovalon. The participation of the auditors here today do not indicate an endorsement of Inovalon, although we're very happy that they're always take time out of their very busy audit work weeks to join us. We will be going through the technical specifications and audit guidelines. If you have questions specific to your health plan, please work with your auditor. Although Tina and Laura here can obviously provide their feedback as an auditor, please work with your own. And with that, since we have a lot of ground to cover, I'll turn it over to the ladies.
Great. Thank you. Hello, everyone. As Courtney said, my name is Laura Hart, and today we're going to go over a look at measurement year 2023. Then Tina's going to go over some notable changes for 2024, and if we have time, we will hit on 2025, and then open it up to questions if we have time. And as Courtney said, if you guys have an opportunity or if you have specific questions, please work with your auditor on those. So, thinking about, that's us. Okay.
All our glory.
All right, so we're gonna start with measurement year 2023, a rewind to look at it. So I have to ask you guys, when you think about last year, how many of you had vacations planned immediately after? How many of you had to actually move that vacation because NCQA moved the deadline? Yeah. That was a weird one, wasn't it? The late notice there was very, very different. So we always talk about HEDIS being a marathon and not a sprint. And as such, you guys have to make sure that you're prepared, you've trained, and that you have a strategy for success when you think about the continuum of what it is that we have to do in order to report HEDIS. The other thing you have to do is make sure that you are adaptable, because inevitably there are obstacles and challenges that happen, and you have to renegotiate your game plan, if you will. So when we think about this last season, we definitely had that happen to us, and it happens every year. If you've done one HEDIS season, you've done one. So that is just something that you have to take with a grain of salt and just be as prepared as you can for the next season. So as we got ready for measurement year 2023, one of the things that we did is we have to think about things as kind of like over the years. So one of the things that we do is we take a look and we think about what are the trends? What is it that we need to monitor, to think about as we prepare for the audit season? So this last year, we really wanted to kind of focus on, all right, so we're out of the pandemic. Where are we with regard to utilization of services post-COVID? And so that was one of the things that we wanted to look at. Another thing was, we all know, redeterminations. That whole process happened, or started last year. And so what was the impact of that? Well, we all know that it varied by state. It depended on when they, started implementing that and looking at it. So that was another thing. We really didn't know how that was going to happen because it all depended on the rollout. The other thing was, are your data sources having the impact that you would expect? And so, yes, we get those supplemental data impact reports, but what exactly are they telling us, especially when we start thinking about multiple supplemental data sources and when they are loaded? So does that impact what the hit rate is? And then how do we look at that? How do we really like dig in to those pieces? So those were all big items that we wanted to make sure that we focused on for 2023. And I will say, the response to all of those was kind of, it depends. A typical consultant response, right? So, but it did depend on the health plans, how they dissected their data, and what the markets were actually doing in order to get the members out to the providers to have specific services performed. So that was sort of high level. Then we had NCQA release the new roadmap. How many of you guys loved the new roadmap?
Nobody.
I just saw one hand.
I put it down. I did.
You put it down real fast. Oh yeah. So there's pieces of the roadmap that are really great when you're looking at it. I actually like the Excel version of it because you can, especially if you're looking at multiple systems or processes, it allows you to look at all of that. So in sort of like a streamlined format. The big thing is that this was a huge learning curve for all of us. We had the new data inventories. Everybody kind of interpreted questions differently, and depending on how you put things together, the reconciliation between the data inventories and the Section 5s and all of that could be a bit of a pain, I would say. So there's lots of moving parts when we think about the roadmap. And I would just say it is a learning curve. I hope your auditors were patient with you. But I anticipate that as we get more familiar with that roadmap, we'll be able to dig down deeper into what it is that we actually want to see. Last year was sort of like, all right, let's see what we get. And then now we're going to work on fine-tuning. One of the things that we want to make sure of anytime we're working on HEDIS is that we have the right people, that we're reporting on the right population. And that is something that we continually find there are struggles because there's lots of different ways that you can define populations. So we want to make sure, especially as you guys are working through the process, defining your population so that they all get into the right projects within your Inovalon software. These are the things that you guys need to be asking and double checking and getting sign off on across your organization. So who is included, making sure that we've got the right product line. Do you need any kind of NCQA approval before you move forward? So if you're combining products, you have to get like the PPO, EPO, you have to get approval for that. You need to make sure that it ties to your accreditation project, if that's what you are doing as well. Benefits. Benefits seem like, oh, they either have this or they don't. Well, it's not that easy. And we find that especially at the group code level and looking at these, there can be some idiosyncrasies that you may not take into account when you're looking at it because you're kind of high level. So you need to make sure that you are digging in, you really know what those codes mean, and you have the sign off for those benefits so that you aren't including people as having like the pharmacy benefit when they really don't. The other thing that we want to make sure of is that you have all the history linked. So we know that we've talked here about all this data. There's so much data that you guys have. It's coming from legacy systems. It's in this warehouse. You have enrollment in this warehouse, and you have the claims in this one. It all needs to come together, converged, so that it can be reported, right? So you need to make sure that you've got all of those pieces together and that you've identified them all. You also need to double check your flags. So if you are reporting Medicare, how are you identifying hospice, LTI, death? How are you getting all the details for your stratifications? you should be going throughout the year at different points to double check to make sure those CMS files are in fact populated with the flags that you want to see. So making sure that all the data is lining out as you would expect, that you're trending it and tracking it, and that way, if there is a problem, you can follow up and investigate that in a timely manner. And then really overall, what are you doing to verify your population? Are you trending it year over year? Do you have sign-offs? Who is looking at it to make sure that you've got the right people and the right projects? Performing a prospective review can also be very beneficial for you. You can look at last year we saw a lot of clients look at the impact of the required exclusions. So remember last year we went from having optional exclusions to all exclusions were required. So what did that do? Also, we had specific measure changes that we really weren't sure what was going to happen with them, and I've listed them out here, kind of like looking at frailty, some of the shifting exclusion logic for certain measures, and then, if we had any age range changes, then that also can impact who's qualifying. So what did that do? And as Tina goes through her section, think about that with the changes. You're going to want to look at that to see how those changes are impacting going forward. And then, of course, there's always plan-specific changes that occur, so you'll want to look at that. So if you had a big group come on, what does that do to your eligible populations, and things along those lines. So we know with NCQA's introduction of the new roadmap, and as we've talked about here, it's all about data. So understanding each source and the steps that are taken in order to take that source table or files and get them into the data file layout so that they can count is incredibly important. Knowing your source to target mappings and ensuring that you're accounting for each piece. Remember, you still have the history that needs to be in here too. These were all things that we really wanted to make sure were areas of focus this last year. And the communication of changes is essential. So if you have data warehouse changes or vendor changes, even something as simple as, oh, this one file wound up, it had to go through some type of QA, so it hadn't been loaded yet, that could significantly impact you when you're working through production. So making sure you understand those types of things is incredibly important. And then you also want to make sure you validate and trend going forward so that you know when there's discrepancies and you can account for those. And so when your lovely auditor comes to you and says, what is happening here? You can say, oh, we know this is a downward trend with pharmacy and blah, blah, blah. We're looking into it, we're fixing it, whatever the case may be. That's really important. Supplemental and electronic data, oh boy. We have the impact of transitioning from those traditional measures to ECDS. So we already know for breast cancer screening, we already fully transitioned. This year, we're transitioning, or we have colorectal cancer screening. It's fully ECDS. And then we have more on the way. So making sure that you understand where those gaps are, how you're going to close them, whether that's through more supplemental data, off-season abstraction, AI, NLP, whatever the case may be, that's what you want to make sure that you have a grasp on. Also make sure that you are exploring your submitters. So your data submitters, making sure nothing's missing, that you've got all of the pieces there, and that you do have a solid process for accepting and onboarding data. Because as they've said multiple times here, garbage in, garbage out, you gotta make sure that data's pristine. We also saw a reduction in the number of DAV sources that were utilized this last year. So that number went down. And really the big thing, guys, do you QA enough? That really I think is one of the big things with the data, is making sure that you understand where it's coming from, that the data is correct, and it does tie to the original source. So make sure you QA, make sure you keep those reports, because if your auditor asks, they will want to see what you're looking at. So making sure you understand what is the primary source for that QA. So new measures, we had some new measures this last year. Dental measure, the OED measure was reported for exchange and Medicaid. Based on what was submitted for our clients, this sort of just gives you an idea of what the spread looked like. So for exchange, we had really small numbers for the most part, because not a whole lot of people have the dental benefit. And for OED, you have to have the dental benefit. So the numbers looked, they're just small. PPO did do better than the others, but there really wasn't a whole lot there. For Medicaid, we did see higher rates, and they had like a 30-point spread from the 10th to the 90th. So there's quite a bit of variation there. For the topical fluoride for children, the TFC measure, again, it's Medicaid only, and the range on that one was about 20 points. For the deprescribing of benzodiazepines, that one was not required to be reported in year one. So the numbers were somewhat small for what we looked at, but there was only about a 10-point variation between the 10th and the 90th. So those numbers are clustered much closer together, and the HMO rates and the PPO rates were very consistent. And then the EDH measure, this one was Medicare only again. It was not required to be reported in the first year, so lots of people took advantage of that. And this measure was sliced and diced. That's really all I can say. So when you get into the duals versus the non-duals diabetics, and then you have the insulin breakout, like the numbers were tiny. So that one's gonna be a little bit hard to judge kind of going forward. But we'll see what happens. The social needs screening and intervention measure. All the phones come up to take pictures on this one. Okay, so for the SNSE measure, we had definite stumbling blocks for it, because there were significant issues with finding the data. The screenings and the interventions, we saw adaptation of tools. It's somewhat difficult to figure out, does it have to match exactly, what exactly is a cultural adaptation for screening, and how does that impact what gets approved? There's definitely gaps in the documentation, and then also with the LOINC codes, there were some issues there. So for first year reporting, we had really low baseline rates. So when we look at the number of people that were having the screening, those numbers were really low for the rate. The eligible populations were quite large, because it's like the normal population. But the number of people actually getting the screenings that you had data for were tiny. So then when you think about that, where essentially half of all the plans that reported a rate of 0. So we had really, really low rates. So then when you think about the screening and how you qualify for that, those eligible populations were like 0 or very tiny as well. So everything's kind of skewed at this point with the SNSE measures. And so there is variation by market, but overall, we need some education happening. You guys need to learn where these screenings are being housed and how they correlate to those codes. So keep in mind when you're looking at this that the intervention timeframe, you have to look at that intervention timeframe for that second piece, because it's not just any time. There is a specific window when that intervention has to occur. Stratifications, SES, the socioeconomic stratification that got added to the EDH measure that we were talking about before. Make sure you're monitoring those CMS reports as well. And then we have race ethnicity stratification. So for this one, we had updated columns to report. So NCQA sort of changed the way that that was all lined out for you. They added in those CDC race ethnicity codes, which were very helpful, I do believe, in making sure that for the data that you are getting, it does get counted. But the big thing that happened is that they added the race diversity, the RDM measure, to the accreditation scoring. And that was something that we weren't quite, not everyone knew about in the beginning. So making sure that you have focus on those direct sources, and then making sure that you're careful of new data is really important, because we're seeing an influx of all kinds of stuff coming in as plans scramble to get that information, especially for the commercial lines of business, because that's the one where it's the most lacking, I would say, as far as the data availability. So making sure that you have solid sources that you're using, and just don't get caught up in just like, oh, we just have to do this. Be mindful of what you're accepting. So make sure you're communicating, talk to your auditor, know the reporting updates. Tina's gonna tell us all kinds of stuff about that. You guys make sure you know of layout changes for the software. Know how the software's counting things, because it's very important, especially as we go forward with new member requirements. So keep up with what the future of HEDIS is holding, know about your risks, and monitor your vendors, all of your vendors. You want to make sure that, we all know there was a cyber event this last year, so making sure you have a backup plan, and making sure that you are prepared for that. I mean, you can only prepare so much, and then you have to deal with it, but make sure you have that stakeholder buy-in for that. And biggest thing, you guys, QA is not optional. You need to make sure that everything is documented, you know what's going to happen, and you have reviewed your data, and then follow through with whatever action is necessary, whether that's pulling data or working with the provider to ensure that it is appropriate.
Okay, thank you.
Yep.
I agree 100% with what she has to say. Okay, now we're going to be off to the races here. Notable changes in measurement year 2024. Courtney and her team have thoroughly digested and understand every minute piece of this. But if you are at a health plan, it is not Courtney's job to understand your data to the nth degree. You need to understand your own data, and with Inovalon's help, you're going to be just fine. So let's start in with some items that we want to bring your attention to. So every year there's retired measures. We all get excited. Oh, but sorry, some of these are not really retired. They're moved to ECDS. That won't make a difference, will it? You might want to look at your rates. So when you have something that has moved to ECDS reporting only, take a look. Are those measures the same? Are those rates the same? If they're different, start pulling some numbers and see, why are they different? Is it appropriate that they're different, or are you missing something? There are a few measures that are retired for real. Naturally, they're either easy measures or unimportant measures. Some of these tabular measures, NCQA just thinks there's either no room for improvement, or there is other measure out there that might provide a better signal of quality. So there's our list of, quote, retired measures. So next slide, new measures. So this is kind of a catch-up year, so there are no truly new measures this year, but stay tuned for measurement year 25, because So you think there won't be a lot this year, but when you start digging into it, you actually see there's a lot of cleanup and little changes, and so we want to bring your attention to a few of these. So next slide. So overall changes, they combine value sets, and that may impact processing speed. The general guidelines, they're in different sections before each domain, so people that are really into the tech specs, it's like you got to look at these general guidelines and not go straight into the measures, but some people realize that they just go straight into the measures. So NCQA is taking a lot of things from the general guidelines and pushing them into the individual measures, so that kind of makes things a little longer. One thing to note is Appendix 3, I don't know who reads appendices on the tech specs, but it used to be just, exactly, hand up, the practitioner types were the only things listed in there. And if you go and look at Appendix 3 now, there are 123 terms in there. So this is kind of good, actually, in some respects. There's audit terms in there, tech spec terms, managed care terms, IT terms. So if you feel silly asking questions, which I continue to learn new things even after many years, it's like, oh, that little appendix there was nice, so check that out. Okay, next slide. General guideline changes. NCQA removed the numbering of the general guidelines. Does anybody on earth know why? Yes, start the boos now. Boo. Why? Why? I want to drop to my knees like a meme, and it's hard enough. I feel, and I don't know if Laura agrees with this, yes. I feel like 90% of being an auditor is knowing where to find in the tech specs the answer, because the answer is likely in there, but you got to find it. So it's like, how good are you at searching? So that was not my idea to remove the numbers. There updated some other general guidelines, and this goes back to what Laura's talking about with know your populations, how they're organized, and where they need to be reported. So it's like, okay, so they put things in there, the federal employee programs and TRICARE, put those in with commercial reporting. So they removed general guidelines about deceased members, put those in the individual measures. They clarified some information about supplemental data coming from the data aggregation validation entities. So it's interesting that the language says now, and I quote, the data from ingestion sites that failed validation may not be shared as standard supplemental data. They're non-standard and must be audited accordingly. So if you're using a DAV, you really want to look at which data streams are validated, which ones are not. Hopefully they'll tell you. They should. And work with your auditor to try and get all that data validated so you can use it for your HEDIS activities. Okay, next slide. They also deleted in the general guidelines kind of the one about using events and diagnosis using lab and pharmacy data, included those in the individual measures. They updated the member collected samples a little bit. So last year they were very specific about which kinds of samples counted. And now they've updated that language a little bit that says test results processed by a lab or provider's office may be used in reporting. So this may be an example of technology outpacing specifications and audit guidelines. So that there's a little more room in there. And I'm sure vendors are reaching out to people. So work with your auditors, work with Inovalon, work with your auditor if you're anticipating using anything. Sampling guidelines, use the lowest of, that's just little updates in there. Okay, next slide. Multiple measures have multiple changes. So really the diabetes, they are changing the eligible population to require 2 diabetic diagnoses during the measurement year or prior year. There's a lot of drug use. The Ozempic and Wegovy commercials, they're big when they're just beyond huge. So we're really looking for that diagnosis of diabetes in there. So pay attention and look at those populations and see how those might change. And you want to make sure the diabetics are in and the non-diabetics are out. Okay, next slide, please. We talked about the lab claims, the race and ethnicity stratification, that's expanded to even more measures. So folks that deal with the XML just gets larger exponentially. The CPT Category 2 modifiers, these modifiers mean that the procedure wasn't accomplished, so you probably don't want to include those in there. So another example of putting those in the individual measures along with the advanced illness indicator. So pay attention to that with all the alphabet soup of measures that it applies to. Okay, next slide, please. Okay, supplemental data. Historically, it's used for numerators only. It's used for exclusions too, but some exclusions, but not other exclusions. Well, maybe it should be used for all measures for everything, because if it's real data, shouldn't you use it across the board? So that continues to be an ongoing challenge. This should be taken care of in your measure software, but do pay attention that it's really on a measure-by-measure basis in terms of what's required exclusion and whether you can use supplemental data, whether that removes the person or leaves them in. It's really on a measure-by-measure basis. Clarifications for folks that are doing hybrid, that unknown is not numerator compliant. So if someone had a lead screening test, but you'll see in the record, result unknown, previously that was kind of on the fence of whether you could use that, but you can definitely not use that. CDS, some definitions and member allocation language has been updated. Next slide, please. Exclusions, KD updated some dates. Withdrawal management detox on the FUI do not meet benefit criteria. Goes back to what Laura says, that benefits are applied kind of at that higher level, not at an individual level. Age range changes on LBP. Okay, next slide. PPC has a little bit of changes in dealing with multiple deliveries. So one thing we're recommending to people is whatever your oversample is for PPC, you may want to bump that up this year if you're reporting that hybrid, so that you can remove some of those multiple births or people that used to be included in the measure that may not be included in it this year. APP, the first line psychosocial care, has been updated a little bit. Antibiotic utilization for respiratory conditions, they clarify that higher or lower counts are not an indicator of performance. It just is. It's like, what's the target we should be looking at? No target. Okay, next slide. Plan all-cause readmissions. So this is a tweak, or just pay attention. Commercial Medicaid duals, you report them in commercial only, and Medicaid, Medicare, and MMP duals, you report in Medicare only. Isn't this all easy? It just gets easier and more streamlined every year. ENP has a little bit of language added to calculate member months. That should be done for you as well. Okay. Medicare comes out with their memo every year, the newly required for the COLE measure, so we'll see how that impacts people's rates, and now those 8-year-old colonoscopies in people's medical records may be hard to find in their ECDS data. So we'll see what that result is, and that will be something that folks will want to dig into. Exchange added a little bit of measures as well. Okay, next slide, please. Okay. Miscellaneous audit changes. Now your auditors are permitted to do your audit review meetings as early as December, but you have to have a roadmap done, so if you want to get a really early start. Non-standard supplemental data, the kind of pencils down date on that is February 28th. Please don't contemplate new supplemental data sources next February. Although people do every year. They're like, I got a last minute one. It's like, you should be looking at that now. The supplemental approval date will still be the end of May. The plan lock date this year is Friday, May 30th, with a marked final deadline of June 13th. And we are at the 9 p.m. Eastern, so people come in at the last minute when they have to put an exact time stop on these. Okay, next slide, please. The changes to the roadmap, Laura already talked about that. They continue to evolve, have added some cybersecurity questions and talking about race and ethnicity mapping. So talk through your auditor about those. The interesting thing with the kind of audit requirements for race and ethnicity, and this is interesting, and here's the exact quote: corrections are not required for any notable RES findings from rate review. However, the reporting organization must acknowledge the results as valid. So it's like, oh, that's wrong, but if it doesn't impact the overall rate, you're still reporting it. Auditors are not expected to make bias determinations. So the RES stratifications are still a work in progress. So we look at the mapping, but there's a lot to learn about the different ways to map, much more than you ever thought. So we're not to the point yet of telling you, I'm sorry, that person is not the correct race and ethnicity that you have described them. But you can see that's the direction that folks would like to head. Okay, next slide. Looking ahead to measurement year 2025, just spend 1 minute on these. There will be new measures next year, continuing to move measures through ECDS reporting and retiring hybrid methodology for eye exams. Be scared on that. Again, that we'll see what kind of impact that has. Next slide, please. There will be several new measures next year, and next year they will remove the data source reporting of direct versus indirect. So that makes me happy. Next slide, please. So really, if we sum everything up, drum roll, no new measures this year, but a lot of little changes that when you dig into it, you go, wow, it adds up quite a bit. So as Laura said, QA, dig into your data. Nobody should know it better than you. There will be more changes on the horizon for MY25, but really focus on measurement year 2024, and we hope you have a happy HEDIS season. And I'm looking at my clock, and it says 11:30. So the session is over. Any questions? like that was convenient.
I was going to say, I have so many questions, but I'll let the audience, if you guys have any questions for Tina or Laura. Oh, Terrence.
With the clarification on being able to use supplemental data sources for measures like PCR, are you seeing much more rise in the use of of those supplemental data sources?
We're seeing a rise in supplemental data sources.
Period.
Period. Like end of sentence. They just continue to proliferate.
Was at your conference, you did a poll of the audience, and it was like 10 or more supplemental data sources, and that feels like a little. We have some of our national plans that probably have 100 data sources. It's a lot. I don't envy either of you in reviewing them.
Well, when you see the difference to the next cut point, and it's 0.0000 something.
Yep.
You go, how many people is that? Oh.
I had a question on supplemental data. So you mentioned near the beginning that, of course, it doesn't really, at least I think with Inovalon, it doesn't really matter when the data necessarily was loaded or received, like what order. Is there any plan, because we're getting sometimes supplemental data from 3, 4, 5 different sources, the same record, right? And it's hard run over run then to determine what actually, because the numbers change so much about where the impact is.
Right.
Is there any plan to address that either from the auditor side or from Inovalon's?
So that was the point of the slide, was to figure out, where is the hit actually coming from?
Yeah.
And that becomes really important, I think, too, when you start getting into the ECDS measures, because everything is flipped. Like the hierarchy is flipped on what counts where. Yeah. And so I think it's really important that you understand where the hit is coming from. And yes, we do see that a lot. Like there's multiple the same record in different sources, because the providers share data too sometimes. So that's coming through, and it's like, well, where is the hit? And
part of it will be dealt with in the specifications in terms of that priority and hierarchy, and then there will also be part of it where you will have to make an internal decision to say, if it comes, we'll prioritize first this source, then that source, because we trust this source more. Yeah. And some of that will be an internal decision that you'll kind of run through with your auditor.
Well, I think some of that is on the Inovalon side too. I mean, as we've seen this balloon and balloon and balloon, you're seeing multiple records from the same source. I mean, we'd love to talk more about hierarchies and stuff, and as that becomes more and more important, as you're seeing the same data show up in so many places, I think it'll be challenging though in, like, is it a measure by measure thing that this hierarchy is more important because it has race and ethnicity stratifications, and this one has these clinical evidences? So it's a really challenging problem to kind of tackle, but yeah, we're certainly open to talking more about it.
Yes.
So I have a question on the race and ethnicity side. Like, how do you guys audit that? Like, how do you audit source mapping on that? Any advice you would give? I know that's challenging, and now you got RDM now in CRED.
So I think that's an evolving front.
Is NCQA providing guidance to you guys?
NCQA has, this year, they provided some guidance on what it is that we are supposed to do or what we are not required to do.
Okay.
So, in looking at the mapping, just, is it
So
reasonable?
it's presence
but it's
of that
more-
and documentation.
Yeah, and
is a
it's
good
more
starting place.
also, they want us to look at, okay, you said you mapped this, then we want to make sure that that is what actually got applied. That's the guidance.
Okay.
So it's evolving.
I know they're telling us to cut this off. I know this is one of the best sessions of the day. Do we have time for one more? Nick, no? Okay, go on, Tuan. Yeah.
So just a quick question, I would love to hear you guys' thoughts and insight on, so as we're looking at forward looking and knowing that by 2030, hybrid kind of going away, I guess my question is more around, do you guys have any insight or thought around insecurity plans or even like partnering with CMS, like how are we looking in and capture some of that data from some of these smaller like provider groups, like mom and pops that are not quite there yet from a data perspective, in which there's still going to be like a gap in reporting for some of those areas because we're not able to, at least from a hybrid perspective. Of course, there's other ways to get this data, but just thinking just in general, as we're kind of looking at overall how providers may actually, provide care.
Yeah, I mean, that's a really good question. I know a lot of teams were putting together policies and procedures and looking out at all other provider networks and seeing what's out there and really identifying, is this going to pass a sniff test with you guys? Making sure that the data are reliable. All right, I'm getting a from the back of the room. Sorry, Nick. Sorry, guys. Thank you, everyone, for attending this session. Thank you to Tina and Laura.